Thanks, Dietrich. These are my disclosures. And you've already heard some of the basic information regarding Scheuermann's kyphosis, the second most common pediatric spinal deformity. And about half of these individuals have apical pain. They also have tight hamstrings. And we've gone over the variable radiographic criteria. These were covered in the last talk. Angular deformity greater than 45 degrees, but disc space narrowing, irregular implates, vertebral body wedging, and Schmorl's nodes. These are the current surgical indications, and they have been changing. They've been changing a lot in the last decade because of increasing information that's come about regarding the natural history of Scheuermann's kyphosis. So possible indications for surgery include pain, if you had significant kyphosis not relieved by non-operative methods. Progressive deformity. Now, what do we mean by progressive deformity? I think this is one of the hardest questions for us to answer today. Initially, in the literature 2 decades ago, it was around 75 degrees. But now, with a better understanding of the natural history of this disorder, which I'll cover in just a moment, it's going up to 80, 90, and some people even say over 100 degrees. And I'll leave that to your discretion because there is no evidence that says which of these we need to really choose from. It's a combination of things between you as the physician and the patient in helping to make the right decision. You've already heard the neurological compromise is rare, as is cardiopulmonary abnormalities. Cosmesis is another thing that needs to be considered as a possible indication. The one thing I think most of you in the room are familiar with, and those of you who are not, you really need to be aware of this article, and now it's approaching 20 years ago. But this is the natural history and long-term follow-up of Scheuermann's kyphosis from the University of Iowa. Stu Weinstein has been famous for his ability to go back and bring back previous patients from their institution and to study them well into their adult life. And this is another example of that. They were able to find 67 of 118 patients that were treated back in the 50s and 60s. Their mean follow-up was 32 years. And this was after their last visit. And they all had a mean kyphosis at that time, not at the initial, but at the time they were being analyzed at 71 degrees. They were then able to create an age-matched comparison group of 34 patients. They completed a questionnaire, had a physical examination, pulmonary function studies, and radiographs. And this is what they found. Scheuermann's patients had more back pain as adults. They had lower activity type jobs as far as their employment was concerned. They had somewhat less truncal extension. They had different location of pain compared to the standard adult with back pain. And they only had restrictive lung disease if their curvatures were over 100 degrees. They found no difference in level of education, absences from work, self-consciousness, self-esteem, social limitations, level of recreation, and they tended to have normal pulmonary function studies if their curves were less than 100 degrees. So a pretty benign-looking disorder 32 years after skeletal maturity. So now, anyway, if we're going to contemplate surgical intervention on a Scheuermann's kyphosis, these are some of the things that we need to go and do preoperatively. Everybody needs a careful spine and neuromuscular examination. They need radiographic evaluation, and that typically consists of the PA and lateral standing entire spine. And we'd like to get a lateral view over a bolster to assess flexibility of the curve. If they're having pain, if they have any neurological symptoms, anything that worries you, by all means you're going to get an MRI to see what the spinal cord looks like, make sure there's no associated intraspinal abnormalities, no significant spinal cord compression. If you need to have consultants because of your concerns about pulmonary status or cardiac status, those need to be obtained preoperatively as well. Some of the current controversies surrounding Scheuermann's kyphosis, as I've already said, the indications for surgery, what level, what curve magnitude constitutes an absolute need for surgical intervention. The other big concern, and this is a concern that I have, and you'll see this get evolved as I go along today, is the necessity for an anterior discectomy and fusion. Do you need to remove the disc across the apex of the curve to improve flexibility and to enhance your fusion? And this can be performed by a thoracotomy, or it can be video-assisted thoracoscopic surgery. And then the other controversy is how do we prevent cervical-dorsal junctional kyphosis, which is one of the more common complications associated with the surgical intervention of this condition. So, procedures. We already heard in the last talk that there are a host of procedures that are available. This can consist of a standard posterior spinal fusion and segmental spinal instrumentation, pedicle screws, or there can be hybrid constructs in which pedicle screws are used distally and hooks in a claw construct used proximally. Anterior spinal fusion followed by posterior spinal fusion and posterior segmental spinal instrumentation. Kind of the old way of treating this is still very applicable. And I've already alluded to the fact that it worries me because of the basic principles which I was taught when I was a resident and fellow is that you want your bone under compression. You want your fusion mass under compression, not under tension. And I do worry about the concept of doing a posterior-only fusion instrumentation. What's going to happen over years? Now, I don't have any data to say that it's not going to work. It's just a concern that I have. Anterior spinal fusions and anterior spinal instrumentation has been suggested. It has not been very popular. I think now we're seeing a lot more use of osteotomies, Smith-Peterson, Ponte osteotomies, pedicle subtraction osteotomies as another way of increasing mobility and achieving better overall correction. Now, fusion level guidelines. Again, no firm data in the literature that tells you how to choose this. The invertebrae proximally should be high in order to try and prevent proximal cervical dorsal junctional kyphosis. So I typically am going to go to T2 or T3. I've never had a case of proximal junctional kyphosis in Scheuermann's kyphosis. Maybe I've been lucky when I say that. Some people even consider fusing one level higher than instrumentation, and again, to give that little extra reinforcement to try and prevent this complication from occurring. We're going to use a compression cantilever technique in order to try and correct the kyphosis, and we should go distally, usually to the first lordotic vertebrae. So typically you're going to be taking the instrumentation down to L2 or L3. A lot of this decision can be made on the flexibility of the curve as well as what your standing lateral radiograph looks like. So, factors to consider. And this is, again, generalities gleaned from the literature. No hard and fast rules here. Curve rigidity. If it corrects to less than 50 degrees on hyperextension, posterior-only fusion and instrumentation. If you have curve severity, 75, 90 degrees, consider anterior spinal release or a discectomy and fusion. And if it's really a big curve, 90, 100 degrees or higher, I think in most cases you're going to need an anterior release, posterior spinal fusion, segmental spinal instrumentation, and probably osteotomies at the time of your posterior procedure. Here's a girl as an illustration, 13 years of age. Scheuermann's kyphosis is back in 05. 100 degrees of kyphosis corrects only to 78 degrees over a bolster. Here she is. This is her 17 months after an anterior spinal release of VATS, posterior spinal fusion, and segmental spinal instrumentation using what I call the hybrid construct. It's a claw construct on each vertebrae, going down and then using pedicle screws in the thoracolumbar and lumbar spine. So down from 100 down to 42 degrees and pretty normal lumbar lordosis. This is another child, 13 years of age, female with Scheuermann's kyphosis. She looks kind of heavy here. She has a horrible-looking deformity, as you can see. 120 degrees of kyphosis, no associated scoliosis. Only corrects to 88 degrees over a bolster. And at the time we did her surgery, we found that she had 4 levels of apical autofusion. So this girl got 4 Smith-Peterson osteotomies. She got an anterior release, posterior spinal fusion, and she got, again, a hybrid-type construct. So from 120 down to 57, this is what she looked like. And this is what she clinically looked like. And I was amazed at how much thinner she looked just by elongating her trunk and giving her a more normal truncal appearance and alignment, much more symmetrical than she was preoperatively. And there she is. This is, again, 5 months after surgery. This is a 20-year-old 95-degree curve and an all-pedicle screw construct, just showing that you can do this quite well with all pedicle screws. Again, this went down to L3. She had 5 Ponte osteotomies. Now, possible complications from surgery, and they certainly are some, and they were listed in the last talk, but neurologic injury, certainly we all know that kyphotic deformities give us the highest incidence of potential neurological complications in spine surgery. Post-operative infection, bone fracture, hardware failure, the cervical dorsal junctional kyphosis, progression of kyphosis, and persistent back pain. These are all possible complications of surgery. This is a girl that I saw 1 year after she had surgery at another institution in which the instrumentation had failed distally, and they'd already trimmed the rod twice because of elevation of the skin and discomfort, and her curve has progressed up to 96 degrees. And when we explored her, we found that the instrumentation in the thoracic area was intact, so we actually left the hooks in place, which is not a pattern that I would prefer to use, but we were able to add the lumbar pedicle screws distally and bring her back into alignment, and she's healed fine. This is her 2 years after her revision surgery. This is another girl. She's 16 at this point. This is in June of 2007. And these are pictures she sent to me that didn't get her initial preoperative photographs. But same situation. Lost her fixation distally, trim, and trim some more until it was taken out at another institution, and then came to see us with a 105-degree curve, and somewhat stiff, a lot of pain, not happy the way she sits, the way she can drive her car, and felt something else should be done. So we explored her. We did find that she had 1 pseudoarthrosis, but we did outline her for numerous Smith-Peterson osteotomies, and then we did all pedicle screw construct, as you see here. And we brought her down to 51 degrees. And you can still see these did not pull out. These screws are not pulling back in the lumbar spine. The one thing that's interesting about her is that because she had had previous surgery, the entire gutter over the lamina is filled with bone. And that was visible on the previous film. So everything is sitting up much higher than you normally would expect. And this was August of 2007. This is what she looked like 10 months later. You can see the little lumps where the pedicle screws are. Those persist until this time, and again, it's because of the increased thickness of the bone at that level and the fact that it's more prominent just being beneath the skin. And here she is. This is where we just saw her just in July of this year, with basically no change in alignment. She's got a solid appearing fusion. Back pain is resolved, but I'm not happy with her clinical appearance because of the prominent implants. But at this point, she doesn't want to have them taken out, and I'm not real anxious to take them out anyway, but I'd like to. This is the last case I'm going to show, and it drifts away from the Scheuermann's kyphosis, but also gives you an idea of what you can do by adding halo traction to your treatment method. And this is a boy, he's only 7 years of age. He had a grade 3 astrocytoma that was removed in 2005, and he had a laminectomy from C2 to T8. And you can kind of know what the history is going to be at that point. 135 degrees of upper thoracic kyphosis. He still has some neurological impairments, a little spastic, but he does walk. And when we saw them, we consulted everybody, the neurosurgeons, the oncologists. Our initial feeling was to leave this child alone, but the family and mom's a nurse was quite insistent that we do something, because not doing something basically doomed him to progressive deformity and increasing neurologic compromise. So we agreed to start and go slow and see what we could accomplish. And we did 2 months of halo traction. We pulled him out to what you see right here, which looks pretty good. And then with our help of both neurosurgery and one of my adult colleagues, because they're much more familiar with lateral mass screws and the cervical spine than I am. And so we basically fused from C2 down to about T10, as you see here. And you can see the middle illustration showing the cantilever technique of helping to get rid of the thoracic kyphosis. And this is what he looked like when we got done. And he's really come out quite well. He was able to continue. His ambulatory status was improved, but unfortunately this boy succumbed this spring to metastatic disease. And so I do think we made his last years of life much more pleasant for him but in the end, it did not solve the entire situation for him. So, in summary, everybody, there are conclusions about Scheuermann's kyphosis and kyphosis in general. Surgery has to be individualized. Pain, curve severity, flexibility, cosmesis. There are still questionable indications for surgery, and I don't have any fixed ideas, but I am starting to think about surgery usually nowadays at about 85, 90, 95 degrees, not at 75 degrees anymore. And increased use of pedicle screws, I think they're very, very helpful in achieving the type of correction you'd like to have. You can do it safer. I think you can really do a lot of really wonderful correction for these individuals with this type of technique. I have questions about posterior spinal fusion and segmental spinal instrumentation alone. I still tend, and you saw that in everybody I showed you recently, I'm still doing an anterior release. I'm not convinced just yet that I can leave the anterior part alone and leave it and have it under compression without having bone graft material there. So we'll have to wait and see what the long-term results are going to be. Thank you very much.
Thank you very much. I think we should now